Greetings, everybody. My name is Behl. I serve as Associate Director of Sea Grant Program at the University of Georgia. I believe I've been asked to moderate this session discussion because I am leading a project that is focused on promoting community-led solutions to addressing health disparities in the Southeastern Caribbean region. We have four spectacular panelists with us today, everyone. Dr. Maureen Michael, she is the Research Director and Research Associate Professor and Interim Director of the Caribbean Exploratory Research Center, School of Nursing at the University of Virgin Islands. We also have with us Dr. Saria Hassan, who is an assistant professor at Emory University School of Medicine. We're also joined by Dr. Marysel Santana. She is Senior Program Manager with Migrant Clinicians Network. And last but not the least, we have Dr. Tischa Erickson, who is a research social scientist with International Institute of Tropical Forestry with the USDA Forest Service. So without further ado, I'd like to welcome Dr. Noreen Michael to give her opening remarks, please. Noreen, take it away.
Thank you very much. I'm going to share my screen now. So good afternoon, everyone. My name is Noreen Michael, and I would like to acknowledge my colleague, Dr. Laverne Raxter, with whom I collaborated on this presentation. As you see the title, we anticipate that the presentation will provide some insights into links between social vulnerability and public health within the context of climate change. Our presentation focuses particularly on behavioral health of children, youth, and adults in the USVI in the aftermath of two Category 5 hurricanes. We have no relationships to disclose. And this slide just simply provides a summary of key elements of the presentation. It is important, we believe, based on the topic to be discussed, to say a little bit about the USVI context. While the USVI is sometimes referred to as America's paradise, a closer look at sociodemographic indicators suggest paradise might not be the most accurate descriptor. The USVI is multiracial, multi-ethnic, and aging. The USVI is a predominantly low-income jurisdiction with 20% of households living below the federal poverty line and with a median income of $33,964. This is noteworthy since a 2016 study by the Territories Bureau of Economic Research reported that self-sufficiency for a family of two, specifically one parent and one child, requires an annual income of $36,853. And if you go to a household with two adults and one child, a self-sufficiency income would be $54,240. Overall, educational attainment in the USVI is lower than that of the US, with 70% of persons 18 to 24 reporting holding a high school diploma compared to 90% in the US. Just over 20% of residents have no health insurance. And for children between the ages of birth and 4 years old that are insured, they are insured through Medicaid. What we see here is that some of the major climate changes that affect the Caribbean. Every category of impact will test how our policies and safety nets protect and support the most vulnerable in the community. This next slide is just a reminder of the multiple points of impact between climate change and human health or public health. And this is a CDC visual. What we have is you see here individuals who are weathering some waves, and without appropriate policies and interventions, given the social vulnerabilities faced by many in the USVI, there's a potential for catastrophic outcomes from climate change for a large sector of the USVI population. When we think about persons particularly at risk for climate change impacts in the USVI, given the dynamics of the population, at particular risk of persons with pre-existing conditions, the elderly, children, and low-income persons. Again, as we noted, 20% of residents in the territory would be considered to be low-income persons. With an aging population and other demographic realities of the USVI, we are at high risk for negative outcomes within the context of climate change. The next 4 slides provide highlights of 2 studies conducted by CERC in 2018, one in the spring and one in the fall. This is the year immediately after Hurricanes Irma and Maria. Because of time constraints, I will not delve into methodological issues, but share salient findings that speak to mental health impacts of disruptions, specifically hurricanes. In spring 2018, CERC administered the 2017 Youth Risk Behavior Survey in all public secondary schools across the territory, with the overall response rate at 65% based on the total enrollment. For today's presentation, findings focus on questions that dealt with depression and suicide, both in terms of ideation, plan, and action. As you note from the slide, 1 in 3 junior high school students and a slightly higher proportion of senior high school students showed depressive symptoms. With respect to suicide ideation, more than 1 in 5 junior high school students indicated that they had seriously considered suicide, with about the same proportion of students at the junior and senior high levels indicating that they had made a plan of how they would in fact commit suicide. Findings of the next 3 slides are based on the study, Community Needs Assessment, Understanding the Needs of Vulnerable Children and Families in the USVI post-Hurricanes Irma and Maria. We collected data from elementary, junior, and senior high school students, as well as adults receiving care from our federally qualified health centers. All 4th to 6th graders in public elementary schools were invited to participate, as well as 4th through 12th grade students in non-public schools. Just so you understand the scope, only 2 of our non-public schools across the territory declined participation. Response rates range from 75 to 85%. At the elementary level, a 10-item child trauma screen questionnaire was used, the CTSQ, and at the secondary level, the child PTSD symptom scale, or the CPSS, was used. Findings revealed, as noted for elementary students, statistically significant differences in affirmative responses to 9 of the 10 items, with more females responding in the affirmative than males for most items. There were also statistically significant differences in affirmative responses to all 10 items at the grade level, with 4th graders responding yes to most questions compared to 5th and 6th graders. For the secondary school students, based on guidelines for determining PTSD scores, approximately 43% of the students could be at risk for PTSD. And of note is that 7th and 8th graders were more likely to be at risk for PTSD compared to students at the high school level. This slide shows that for adults, the story is similar to that of children and youth. Behavioral mental health impacts are real and clearly documented for the USVI in the aftermath of Hurricanes Irma and Maria. Over half of adults who responded to the battery of instruments showed evidence of depressive symptoms and PTSD, and 7 in 10 showed moderate stress. In terms of coping with the 2 Category 5 hurricanes, adults identified religion as one of the primary approaches to coping with the hurricanes. I'm going to move quickly as my time is slipping by. This slide shows a strong connection between human health and socioeconomic activities and development, highlights the need to pay more attention to policies, practices, and development efforts within the context of climate change impacts, and our need to adapt and mitigate where possible. The final 2 slides really focus on implications for public health policy and research, and just wanted to make a few key points in terms of what we have been learning. One is that cross-sector planning is an imperative. Policymakers at all levels must be committed to addressing climate change and to do so collaboratively. There must be an investment in the preparation of healthcare providers, particularly those who are equipped to address mental health challenges across the lifespan. Final 3 points: preparedness at the community level is essential, and these preparedness plans and activities must reflect an understanding of social vulnerabilities and the social determinants of health. Policymakers must be committed to engaging vulnerable populations through campaigns that facilitate social justice, and we must expand access to high-quality healthcare to all USVI residents. Our references are noted, and we thank you for the opportunity to share.
All right, so thank you so much to the organizers for the opportunity. My role here today is to think a little bit about how disasters, in particular as a climate-induced event, can lead to worsening health disparities. So Dr. Michael has already shown you this. It is the multitude of ways in which climate change can affect human health. But I think as we think about all of these different avenues in which health is impacted, it's important to realize that this impact is not equitable across the board. The climate change effects do not affect all populations in the same way. And this is really the crux and the essence of how climate change will, unless acted upon, will worsen health disparities. So whether we're talking about older adults or children and their different levels of susceptibility and ability to adapt, whether we're talking about low-income communities and both their increased susceptibility as well as their ability to adapt, or we're talking about communities as a whole who might have heightened levels of exposure. And so I offer you today a framework that was provided to us by the Environmental Protection Agency to help us think about how did people experience climate change differently and how different levels of vulnerability will therefore lead to differences in health outcomes. So this framework here basically says to us that climate vulnerability is a function of exposure, sensitivity, and adaptive capacity. Exposure, the level of contact that a person or a community has with the environment. Sensitivity, the degree to which individuals are affected by the changes in environmental exposure. And importantly, very importantly, adaptive capacity. This notion that there's an ability to change the things in your surroundings so that you are better able to tolerate the changing exposures from climate change. And there's a multitude of ways in which people are different by the level of their exposure, by the level of their sensitivity, and by the level of the ability to adapt. And again, this is why climate change will only worsen health disparities unless we act. So allow me to use this framework to think a little bit about health disparities in the Caribbean and how climate change will specifically be worsening health disparities in the Caribbean unless we act. And to do this, I'm going to specifically focus on disasters. Well, why disasters? Primarily because disasters, unfortunately, are going to be a thing of the future for this region. In particular, we know that there's data and evidence that we will see more severe weather events moving forward. But we actually already know that the Caribbean experiences the highest storms per million individuals per year. We also know from very recent history that this has been a fact from 2017 to 2019 to even last year. And so let us first think about exposures. And I urge you to think about exposures in a way that's similar to what Dr. Michael was alluding to, that there are differences across individuals in their level of sensitivity. Oh, sorry. So exposure was the different exposure here in the Caribbean. I'm now going to talk about sensitivity and the fact that different individuals have different levels of sensitivity to the impacts of climate change. And talking specifically about disasters. What we know from Irma and Maria is that at least 1/3 of the deaths were due to uncontrolled non-communicable diseases, NCDs. NCDs include diabetes, high blood pressure, mental health conditions, asthma, cancer, end-stage kidney disease. And what we're finding is that there's an uptick, there's an exacerbation of these conditions in the setting of a disaster for a multitude of reasons. And that's contributing to the higher rates of mortality. I don't have the time to go through all of the data that you see in front of you here that supports this notion of the higher mortality due to NCDs in the setting of disasters. But I do want to highlight the issue of mental health. And I was very pleased to see Dr. Michael also highlight that in her work. Mental health not only in and of itself leads to higher mortality, but we know that mental health disorders will also exacerbate other chronic conditions such as diabetes, hypertension, and heart disease. We've done some research in this area to think about what are the challenges in addressing non-communicable diseases, both as a scoping review, but also as qualitative work in collaboration with the Pan American Health Organization, to think at a regional level for the Caribbean. At a regional level, how can we act and do more to address all of the challenges you see listed here for why we see higher mortality due to chronic diseases after disaster? So we know people with chronic disease have higher sensitivity, but we also know that there are already underlying disparities with regards to chronic diseases in the Caribbean. Not only does the Caribbean have the highest premature mortality due to NCDs in the Americas, but if we focus now on the US Virgin Islands and Puerto Rico, we know that there are several disparities even there. So whether it's the diabetes prevalence in Puerto Rico and the Virgin Islands compared to the general US population, or whether it's federal funding for healthcare that is differential between the US territories and the US mainland. And unfortunately, if we look at deaths per 100,000 people over time, this is data from the Global Burden of Disease Study, we see also that there are significant differences here. And I apologize, the light green line is the US Virgin Islands, the dark green line is the United States. So you can see that as of 2006, the US Virgin Islands has had a significant increase in the number of deaths per 100,000 people. And if we now add in Puerto Rico, we can see also that since the 2010s, we've seen an uptick also in the deaths per 100,000 people. So making the case that there are underlying disparities in sensitivity, that in the US territories and the Virgin Islands, there are already underlying disparities in chronic disease. You add on top of that heightened exposure with higher levels of severe weather events, then we're only going to be increasing vulnerability and worsening our health outcomes. So now let's talk a little bit about the ability to adapt. And there are also discrepancies and disparities in our ability to adapt, whether it's because of low-income communities having access to insurance, having access to infrastructure that can withstand severe weather events, whether it's access to transportation and means to evacuate when needed. We also know that people with disabilities and the elderly are also going to have limited abilities to adapt, especially in the circumstances of severe weather events, which is what I'm focusing on, but really on a global, on a broader scale, even thinking about climate change and health. Unfortunately, adaptive capacity is also dependent on outside agencies and government agencies and their ability to support adaptation. In this case, I think a little bit more liberally about adaptation, thinking about the immediate response after a severe weather event. And this paper that was published in BMG Global Health showed us that there were disparities in the amount of funding that was provided to certain states as a result of the 2017 hurricanes, whether it was Harvey versus Irma and Maria. Harvey here in yellow and red, Irma Maria in blue and green, and you can see that the yellow and red far exceeds the blue and green, but not because there was more mortality in those areas. We can see that direct and indirect deaths from Harvey were very disparate from what we saw with Maria. And so as we turn again to this, if we have disparities in exposure, we have disparities in sensitivity, and now we have disparities in our ability to adapt, we're only going to see disparate vulnerabilities with worsening health outcomes that will only exacerbate underlying health disparities that already exist between the US territories and the US mainland. But one thing that this graphic does not take into account is resilience and community resilience, and the role of community resilience in not only addressing sensitivity and the ability to adapt, but really bringing our communities together to address how we can decrease vulnerability and reduce the health outcomes as a result of climate change, and specifically here in disasters. And I'm really pleased that Dr. Marysel Pagán Santana will be speaking after me to give you a very specific example of how this can be done, of how we can increase resilience and reduce vulnerability in our communities. And so with that, I'll leave you with these key points. Again, climate change does not affect everyone equally. I use the example of disasters to hopefully make that case today. The inequitable effects of climate change will only exacerbate existing health disparities. And we have to think about addressing exposure, sensitivity, and adaptive capacity so we can reduce vulnerability and the health effects of climate change. And I've used extreme weather events as that example, and really highlighting that underlying disparities in chronic disease, the area that I focus on, will only worsen with more severe weather events over time, especially among the most vulnerable.
Dr. Santana, take it away, please.
Gracias. Mi nombre es Marysel Pagán Santana, soy doctora en salud pública y como mencionó la doctora antes que mí, pues voy a estar tratando de presentarles, ¿no? Un proyecto que trabajamos nosotros en respuesta a los desastres recientes en Puerto Rico. Trabajo con la organización Migrant Clinicians Network, que tiene varias oficinas a través de los Estados Unidos y una oficina en Puerto Rico. Este proyecto surgió como una de las respuestas al huracán María en un momento dado y sí tuvo, basado en las diferentes desastres y emergencias que hemos tenido en Puerto Rico, diferentes modificaciones, pero inicialmente pues tenía la idea o la meta de identificar aquellas lecciones y buenas prácticas que pudiéramos reproducir a través del modelo de movilización comunitaria. Y esto de cara a que la crisis climática iba a continuar, como han bien presentado la conferenciantes antes que a mí, va a continuar lamentablemente pues ocurriendo diferentes desastres y emergencias. Así que, ¿qué podíamos aprender y quiénes iban a ser los participantes o quién tenía un rol en el aspecto de respuesta a emergencias? Y ahí es pues donde empezamos a utilizar nosotros el modelo de movilización comunitaria para el manejo de emergencias. La idea fundamentada en la susceptibilidad de la isla de Puerto Rico en aquel momento ante los impactos de lo que es el cambio climático, utilizando también lo que son los centros de salud comunitario, y esto es importante para que tengan una idea del marco que estábamos utilizando para este proyecto. Era la utilización de centros de salud comunitaria, o como se refieren a Puerto Rico, los centros 330, como uno de los agentes principales para la movilización comunitaria, con la meta mayor, ¿verdad? Más allá de la preparación de emergencia, era de proteger la salud de las comunidades vulneradas antes, durante y después de los desastres. Esta parte no la voy a explicar muy bien, la explicó la doctora antes que yo, la diferencia en el impacto de los desastres a través de las diferentes comunidades, sabiendo que hay diferentes características que nos pueden hacer mayor o menor vulnerables a los desastres, y por ende pues el impacto en nuestra salud que es diferente para cada una de las comunidades. Pero es importante tener esto en mente al momento de hablar de la creación de planes de emergencia. Esto no es algo de un solo tamaño, no es algo que puede ser igual para todo el mundo, sino que hay que considerar estas diferencias al momento de la planificación también. El modelo de movilización comunitaria se enmarca dentro de tres áreas principales: la movilización, ¿verdad?, como un ente de accionar diferentes cuerpos o grupos, la comunicación y la gerencia la parte más, vamos a decir, administrativa de un proceso como este. Incluye un análisis situacional, dónde estamos, qué estamos haciendo y cuáles son nuestras vulnerabilidades. Nosotros incluimos también lo que es el mapeo de recursos, quiénes son los agentes alrededor de nosotros, quienes pueden ayudarnos o servirnos en un momento dado, con un énfasis en comunicación y planificación recurrente. Dentro de todo esto, parte de este marco para la preparación de emergencias era integrar todos los sectores para atender un problema en común en aquel momento, o para lo que lo estamos utilizando, era el poder responder en un periodo, no era, ¿verdad?, no es responder como un todo, por lo menos en un periodo de 48 horas, que una comunidad pudiese responder a sus emergencias y necesidades por su cuenta, sin necesitar un apoyo inmediato de diferentes brigadas que tal vez no pudieran accesar o llegar a ellos de manera inmediata, especialmente como con la experiencia que tuvimos con María, para comunidades que tal vez estaban distantes o que estuviesen pues aisladas por alguna situación geográfica o de ambiente. Tiene que envolver todos los sectores, y bien lo mencionaban las compañeras antes que yo, hay que tener una coordinación, no solamente desde el punto de vista del gobierno a responder a las comunidades, sino desde todos los sectores, incluyendo sin fines de lucro, sectores de salud, sectores de gobierno y sectores comunitarios, incluyendo la academia incluso, en el proceso de nosotros planificar para que las comunidades puedan, por su cuenta, pues agilizar, movilizarse y manejar sus emergencias. También pues incluía obviamente un proceso de recursos financieros, no solamente el hablar, ¿verdad?, teóricamente de prepararse para un desastre, es identificar cuáles son los recursos para sostener esa planificación. Y la otra parte, pues que todo el mundo supiera que cualquier persona podía iniciar un proceso de movilización comunitaria. ¿Por qué estábamos utilizando este marco para aplicarlo al manejo de emergencias? La movilización comunitaria se ha usado para situaciones de salud, por la Organización Mundial de la Salud, en otros aspectos. En el aspecto de manejo de emergencia lo entendimos pertinente para Puerto Rico, porque había una situación con la respuesta gubernamental y comunitaria en el proceso de desastres recientes. Porque el mismo marco de la respuesta nacional de los Estados Unidos en cuanto a cómo se manejan las emergencias incluye un acercamiento donde ¿verdad?, necesita que las comunidades estén organizadas y preparadas para poder entonces facilitar, ¿no?, una respuesta gubernamental. Eso está escrito en las diferentes herramientas y planes a nivel nacional, que las comunidades deben organizarse. Y la última parte, pues que cada comunidad tiene su característica única, así que no vale la pena o no es tan efectivo yo crear un plan de emergencia desde el punto de vista, digamos, en el área este de la isla, para aplicarlo tal vez a zonas rurales, a zonas en otros puntos cardinales o inclusive a otros estados, que no se atempere a la cultura, a los retos, al lenguaje, al interés o las necesidades de cada comunidad. Nosotros identificamos, ¿verdad?, con cada una de las comunidades, lo primero que se hizo fue identificar un centro de salud que hubiese tenido el interés y los retos de haber hecho la respuesta a María con sus comunidades, y un interés en particular de la comunidad en querer mejorar su forma de responder. Una vez los centros entraron en una colaboración con nosotros y entablaron comunicación con sus comunidades, empezamos un proceso de identificar retos y oportunidades, recursos y necesidades y desarrollo de capacidades para cada una de las fases del manejo de emergencia. En este proyecto en particular, nosotros pudimos atender comunidades en estos 6 municipios a través de 4 centros de salud distintos en Puerto Rico, incluyendo el Hospital General Castañer, el Centro la Corporación de Servicios Médicos y el Centro de Salud de Patilla, entre otros, para atender comunidades específicas. Estas eran comunidades que los centros habían identificado por experiencia, que habían tenido dificultades para atender a María o que no tenían relación con el centro, que quedaron incomunicadas por alguna razón. Y pues el proceso nos llevó a entender un poco más el el porqué de esa situación post-María y cómo entonces nosotros poder ayudar o empoderar la comunidad para poder entonces prepararse en caso de que algo así sucediera nuevamente. Dentro del proceso de identificación de necesidades ocurre una retroalimentación tanto con el centro de salud y con la comunidad, donde nos sentamos a identificar necesidades con la comunidad. Y esta parte es importante en términos del modelo de movilización comunitaria. Cuando nosotros vamos a hablar de esto, el rol de mi organización, de MCN, y el rol del centro era un rol de facilitador, ¿no? De facilitador de herramientas, de facilitador de discusiones. Pero era la comunidad la que dictaba qué era lo que queríamos discutir. Si en algún momento en particular la discusión iba dirigida a huracanes y la comunidad quería dirigirla hacia inundaciones, había que hacer la modificación. Era importante ese asunto para el establecimiento de una confianza y una relación con la comunidad y atender lo que realmente en aquel momento estaba preocupando. Acá en esta diapositiva pues pueden ver parte de lo que empezamos a tener nosotros como resultado de las diferentes actividades que nosotros llevábamos a cabo con las comunidades y estos centros de salud. El identificar y que los centros pudieran ver cuantitativamente, e inclusive las comunidades, la diferencia en impacto, que es lo que ven enmarcado en color amarillo, para cada una de las emergencias. Y digo para cada una de las emergencias porque a pesar de que el proyecto empezó en el 2018, rápido después del 2018, en el inicio del proyecto, tuvimos el proceso, la situación de los terremotos en el área sur-oeste y luego rápido el proceso o la emergencia de salud pública de COVID-19. Así que el proyecto tuvo que ser modificado porque la atención de la comunidad cambiaba de acuerdo al estresor que estaba sufriendo en ese momento. Así que tratamos de, sin olvidar lo que era la preparación a huracanes, tratamos de abarcar otras situaciones de emergencia que bien pudieron surgir nuevamente o complicar, especialmente cuando teníamos una temporada de huracanes que se avecinaba el año pasado, a la misma vez que atendíamos una pandemia. Preguntas que surgían de esta discusión con las comunidades a través de grupos focales o de mapeos de recursos y discusiones en grupos, era cuál había sido el impacto en salud, cuál había sido el impacto en seguridad alimentaria y seguridad económica. Esa información, a pesar de que no podría ser algo que vaya directamente a lo que yo hago antes, durante o después de un huracán, me daba a mí la información, ¿verdad? A mí como comunidad o como grupo, de qué era lo que yo tenía que atender antes de poder entonces hablar de procesos de preparación de emergencias. Y a la misma vez al centro de salud, que era esa primera, vamos a decir, el primer contacto durante las emergencias, lo fue durante María, y era lo que queríamos seguir fomentando, que hubiera un contacto local con el apoyo financiero y sostenible como lo es un centro de salud. Entender las necesidades de esa comunidad y relacionarlas a lo que era la respuesta de emergencia del centro en sí. A través de este proyecto, pues nosotros desarrollamos unas herramientas con los centros, tuvimos reuniones, esa foto que ven ahí fue pre-COVID, claramente, donde teníamos diferentes discusiones con ellos, y cada centro se iba y atendía las diferentes necesidades a través de talleres, eventos o actividades con la comunidad. Una vez nosotros pudimos implementar el proyecto, hubo 4 planes de preparación de la comunidad, o sea, hubo 4 comunidades que lograron llevar a cabo su plan de emergencias comunitario, un plan de emergencias integrado con el centro de salud, donde el centro de salud tenía un rol no solamente en responder y fomentar esa preparación, sino también en sostener ese plan, o sea que cada año se reúne nuevamente con la comunidad a poder revisarlo. Parte de la información que surge de esa preparación es cosas tan sencillas como saber cuáles son las personas con enfermedades crónicas que tengo yo cerca de mi comunidad, cuáles son las personas que tal vez están encamadas o que tienen alguna vulnerabilidad adicional en términos de su vivienda, su empleo, su acceso a comida. Tuvimos la oportunidad, y es una oportunidad, es lamentable, pero fue una oportunidad de probar, ya llevamos un año en este proceso, de probar el efecto de haber creado este proceso de movilización comunitaria en Maricao y Atillo, porque habían surgido, ya tenían sus planes de emergencias y surgió entonces la emergencia de lo que fueron los terremotos en el suroeste. Con Maricao en particular,
Marysel,
tuvimos una respuesta bien rápido de la comunidad, hubo inclusive líderes comunitarios que se movieron a hacer evaluaciones de impacto, a identificar necesidades de ayuda de cada una de las comunidades y a dirigir, según iba entrando, ¿verdad?, la ayuda o apoyo de las agencias gubernamentales, habían personas con la información necesaria para que esa ayuda pudiera llegar rápido y de manera eficiente a las comunidades.
Hi, Marysel.
Y durante el
I think we have to
hubo 100
wrap up.
comunidades en toda la isla que están en ese proceso, incluyendo el trabajo con las comunidades agrícolas que también son un sector de interés en la organización, las personas que trabajan con la agricultura en Puerto Rico. Lo importante de todo esto es que es un proceso continuo, que hay que identificar las experiencias únicas y el rol de las organizaciones comunitarias en este proceso. La movilización comunitaria no es algo nuevo, pero no es muy reconocido por las agencias de gobierno de tal manera que pueda ser sostenible. Así que es importante reconocer ese rol de cara a lo que es la crisis climática y el efecto que pudieran tener nuevamente estas diferentes desastres para atenderlo, y entonces poder reconocer las pasadas experiencias y aprender de ellas. Y con eso pues termino la presentación. Disculpen por el retraso en el tiempo.
Well, thank you, everyone. Thank you for the opportunity. I think what I'll do, I'm going to try to move this along quickly, but basically my presentation is a little bit, after listening to our panelists give you great insights into very specific information, issues and concerns, as well as great programs in addressing social vulnerability in the context of health. I'm going to take it a little bit in a bigger picture, looking at, well, what do we do with that in terms of the governance of climate vulnerability and resilience? What are the implications to how we understand and how we actually govern vulnerability? And just to give you a sense of my positionality is that although I'm a Puerto Rican woman, I've lived and worked in Puerto Rico most of my life. I wasn't in Puerto Rico during the hurricanes Irma and Maria, but we, with our experiences with urban communities and learning from their stories, as well as my own family, and with other collaborators, we wrote some reflections about some concerns that these events brought up that lead us to give some ideas and recommendations for how we need to improve the way that we approach, the way that we study, and again, and the way that we then in decision making for looking at vulnerability. Oh, sorry. So I'm going to go through these a little bit faster than I wanted to, but basically one of the main things is that even though most of the time in planning and decision making, we use certain metrics and statistics for looking at vulnerability, and as the previous panelist explains, there's ways of defining vulnerability having to do with the exposure and sensitivity, as well as adaptive capacity. And many times we can actually measure these qualities of vulnerability, and we can map them geographically to be able to know where or which communities or populations are more vulnerable than others. And that is very crucial in order to understand and give prioritize where we need to focus our efforts. But we also know, and we learned from Hurricane Maria, that vulnerability is also a product of flows and our connectivity to other places, to other people, to the mobilization of people migrating in and out. And there has been advances in how we can study these and measure these, but also as you saw from the previous panelists, there are elements, social elements that cannot necessarily be quantified or visualized that are super important for vulnerability, like our social networks, like where we get our information from, where do we get our food from, the fact that we were disconnected from income, resources, and supplies and food right after Maria because of our territorial condition and institutional framework, not allowing certain with the Jones Act, not allowing certain provisions of food and resources was a huge factor in our vulnerability. So we need to better account for those failures and the connections that are crucial to our ability to overcome these disasters. These two concerns are related, and they have to do about perception about information and how those can affect what we think is our capacity to respond to some disaster and climate responses, as well as what we perceive others can do. And I think, as well as others have mentioned, the expectations that sometimes we may have of our government and the failure of those to be able to respond, as happened in Hurricane Maria, it was something I think that surprised many of us. But at the same time, we also realize how much of our own adaptive capacity, and especially in the context of many communities that relied on their own networks and their own resources, and realized, they had that ability to really respond and starting to take their own community resilience in their own hands. And a lot has to do with the uncertainty that sometimes is socially created by many times the way that decision makers deal with some of these issues, but also how information flows again are complicated in these situations. And so those are factors that I think have to be taken more into account when we are doing when we're defining vulnerability and addressing solutions. Is these social political structures, infrastructures also has a lot to do with how we're vulnerable. Everyone has mentioned about the need for multi-sector collaboration. I think everybody would agree with that, but it's difficult to know exactly what kind of collaborations we need, where are we lacking information. This social network analysis we did for the San Juan region to understand the actors collaborating around climate adaptation and resilience after Hurricane Maria, and you see that many actors, and to some of you it would be kind of the usual suspects of actors. But in terms of the health sector, for instance, except for a few organizations that address social vulnerability in the health sector, like the University of Puerto Rico Medical Sciences or the EPA, crucial agencies were missing, like the Department of Health. And so I think being able to directly assess how our current networks, what our current connections are, and the lack of connections, where we need to promote more connections and connectivity and new linkages, is part of that process of understanding our own vulnerability and of our governance. And this last one, I think, actually, someone in the chat, I think a friend of mine, Cecilia Ortiz, addressed this question of how to do with how we define resilience. And we also observed during the right after Maria that had this opportunity sometimes we see after disasters to be able to really rebuild, do change, take that opportunity to move toward more sustainable development pathways, was compromised a lot by the discourses around sustainability. Around resilience, because even though many of us understand resilience as actually coming from the literature from social ecological resilience, which view the ability of systems to transform, to change completely, and sometimes dismantle their systems and structures to be able to rebuild. Much of the resilience discourse is around more from an engineering perspective that defines this as building back or building stronger. That's more of an engineering definition of resilience. So you have these different definitions of resilience, and when you look at the responses that come from that, they can be very different. One would be, let's build right to where we were before and resist or that bouncing back idea, but that means we go back to the same vulnerabilities that left us, the same conditions that left us vulnerable in the first place. Whereas in some cases, and you see a lot also in urban community resilience, is that they want complete change. They want social change at multiple levels in order for them to transform, and they take that into their own hands and moving forward to actually see a different possibility for them. So this idea of how we define change is something for us to be very attentive to as we're moving forward with what's next after these climate responses and events. So I'm just going to finish there. Again, summarizing in thinking about the network nature of vulnerability, in how we understand vulnerability in knowledge systems, talking about equity and sharing risk across different levels of society, and a lot of clarity in roles and responsibilities around who's doing what. Thank you. Hopefully that makes sense.
Yes, that was absolutely fantastic. Thank you, Dr. Muñoz, Erickson. Participants, please use the reactions button to give a big round of applause to our speakers, and kindly use the chat window to ask any questions that you might have. I would encourage you to read the comment and question by one participant, Cecilio Ortiz Garcia. Tischa just responded to that question, and hopefully other panelists can reflect on that as well. But in the meantime, I'm going to direct my first question to Dr. Saria and Dr. Noreen. In light of COVID, do you think there are lessons that can be drawn to promote health equity and disaster risk reduction in the Caribbean? And in particular, I'm looking at you, Saria, to help us understand the role that clinicians can play in disaster risk reduction. So Noreen and Saria, who would like to go first?
All right, great. I can go first, and then hopefully get the research perspective afterwards. So I do think that clinicians play a really important role. I won't say clinician, I'll say all healthcare providers who interact with people living with chronic illness, especially in really improving our disaster preparedness and response. We're doing a study now with federally qualified health centers in the Virgin Islands and in Puerto Rico. And our initial results show that less than 50% of healthcare providers are actually having robust discussions around disaster preparedness and response with their patients. And so whether it's the patient on insulin who has diabetes, whether it's someone with mental health disorders who's particularly sensitive. So understanding that these individuals have heightened sensitivity and talking to them very specifically about the impact of disasters on their health is really, really critical. So I will just add that there are many resources for providers to help engage you in how to discuss disaster preparedness and response and the impact of climate on health with your patients. So happy to share those if there's interest.
Fabulous, thank you. Noreen?
I think what we see from the work that we've been doing over the years, and we have not done any data collection since COVID, but I think we are sensitive to the reality that what you had where there were some gaps before, those have just been exacerbated and expanded with the back-to-back Cat 5 hurricanes in the territory. And then while folks were still trying to find themselves the pandemic. And so with our community in particular, we have a significant void in terms of behavioral health providers, psychiatrists, psychologists, and we have had expansions at St. Thomas East End Medical Center in terms of behavioral health care, and they've actually added providers. So I think there's a greater sensitivity on the ground with persons with respect to this. But I think for our community, I think we still see a lot of hesitancy, particularly on the behavioral health side, for individuals to acknowledge the need and feel comfortable and confident trying to get that assistance. I think there's a lot of opportunity for strengthening, expanding those relationships and really strengthening support and safety nets for our communities.
Thank you so much for those insightful answers. My next question is to Marysel. We have heard a lot about the mental and emotional health toll that goes into into responding to these disasters. So Marysel, what are organizations like yours doing to address some of those mental and emotional health needs of those who are impacted by disaster events?
The first one is the programs that access the health and emotional well-being of responders before actually getting to communities. A lot of what we're doing get resources to clinicians and other first responders into how to deal with trauma acquired by treating trauma. So that's the first step. And the second one is the development of programs that target specific needs and situations on communities. That's really important to acknowledge the needs before actually getting into this is just your prescription or this is what you have to do. So have the discussion of what's going on. A lot of hand-holding process rather than just give it kind of like, this is your page and do this and just forget that it's going to likely happen again to you. So, but our focus right now as an organization is actually the first responders and clinicians. So they are actually able to help other people. And I encourage everybody here to go through our webpage. We have a program called Witness to Witness, and allows clinicians to enroll in a process to have support during their trauma-related process when they're targeting communities that are passing by, not only for COVID, but all the other disasters like the California Camp Fire and Puerto Rico hurricanes.
That is fabulous. Thank you, Marysel. I would draw everyone's attention to a comment that Saria has in the chat window about engaging community and community health workers, as well as the website that Marysel just mentioned. One last question for Tischa. Tischa, you mentioned the role of coordination and communication. Can you reflect a little bit more on some specific ways in which we can promote that collaboration, communication, and cooperation across the Virgin Islands and Puerto Rico and the Caribbean, actually?
Yeah, well, I think one place to start is actually understanding or mapping those relationships, like I show with the social network, because sometimes, you know, we tend to do that for the people that we're serving, the communities that we're serving, but we also need to do that for ourselves and to understand where we're at in connection with other sectors, who's missing, who's included, not included, so that we can better navigate those collaborations and where we need to make those partnerships. But sometimes we just don't know, and we also don't know what other sectors are doing. I mean, even here I learn about these great research and project. And so a lot of that, I think, is to understand better what we have, where are we at, who's doing what, to then see where those collaborations make sense. Sometimes we force them without understanding. And then the other thing is that this is really all about relationships. I mean, when it comes down to, I think all of us, we can study and think about this in many ways, but when it comes down to actually living through and in the moment, we realize that all of this, the source of adaptive capacity and empowerment, comes from relationships. So spending time on those before events or tragedies happen, and with other sectors and communities, I think it's time well invested.
Wow, I wish we had more time to carry on with this discussion. Unfortunately, we're out of time. Let's use our reactions button, everyone, to thank our speakers once again. You should, if you need to get in touch with any of them, please do let me know. I'll drop my email in the chat window and we can connect you to the panelists and answer any questions that you all might have. Thank you again, panelists, and wish you all the best. Take care. Bye-bye.